Myself, Dr. Divya from Narayana Medical College. My topic is intraoperative and immediate postoperative outcomes of cataract surgery using phacoemulsification in eyes with and without pseudoexfoliation syndrome. Introduction. Pseudoexfoliation is an age-related abnormal fibrillopathy characterized by gradual synthesis, accumulation and deposition of exfoliation material in the anterior segment of the eye and other tissues of the body. This deposition of material may lead to characteristic clinical and ultrastructural changes of the lens epithelium or capsule, intraocular lens, endothelium, corneal endothelium, trabecular meshwork, iris, ciliary body, jonules and structure of the blood aqueous barrier. These alterations of tissues of the anterior eye segment make the cataract surgery, that is phacoemulsification, potentially challenging, and surgeons must be aware of numerous intraoperative and postoperative complications in managing the patient with pseudoexfoliation syndrome. Phacoemulsification has become the norm for routine cataract surgery. In eyes with pseudoexfoliation, the lens tends to be harder and requires increased phacoemulsification time, which can result in more difficult surgery. In addition, with this technique, pressure on the capsular jonular diaphragm may stretch the capsule and jonules, thereby increasing the risk for jonular tear or capsular tear and vitreous loss. My aim is to assess a comparative study on the intraoperative and immediate postoperative outcome of cataract surgery using phacoemulsification in eyes with and without pseudoexfoliation syndrome. It's a prospective hospital-based study. The duration is about 4 months and sample sizes are taken 80 months for 80 patients, 40 patients in each group. Inclusion criteria: Group 1 comprised of cataract with or without white pupillary ruff and the presence of a manifest classic late stage of pseudoexfoliation deposition pattern in the anterior lens capsule was selected. Group 2 comprised normal eyes with senile cataract and the absence of coexisting ocular pathology. Exclusion criteria includes mature cataract, complicated cataract, previous ocular surgeries, history of ocular trauma, corneal opacities, glaucoma, uveitis and posterior segment pathologies, and eyes with predisposition to jonular weakness and increased inflammatory response postoperatively are the exclusion criteria for both the groups. Data collected from each patient are: all the patients should be preoperatively assessed with age in years, uncorrected visual acuity, best corrected visual acuity, anterior chamber depth, axial length, intraocular pressure, grade of cataract were compared among the test group and the control groups. IOL power is calculated by using contact test and biometry with SRK2 formula. Preoperative investigations like complete hemogram, RBS, routine urine and microscopy should be done. Detailed slit lamp microscopy under maximal mydriasis was performed to assess pseudoexfoliative material deposition on the anterior lens capsule, type of cataract and grade of cataract in the presence of phacodensis or jonulolysis. A detailed fundus examination was conducted and all the observations and demographic data were carefully recorded and using a protocol sheet. These are the results, that is which taken into account is age in years, number of males, uncorrected visual acuity, best corrected visual acuity, anterior chamber depth and IOP, nuclear sclerosis grading 1 to 4 and posterior capsular cataract 0 to 2. Parameters intraoperatively taken were mean pupillary diameter, that is in PXF pseudoexfoliation, that is 5.5, and in group 2 more than 6 mm. And I have taken CCC size of about 4.8 in pseudoexfoliation, and group 2 it is 6. And phaco power, phaco time, and posterior capsular tear or without vitreous loss is indicated in one case, and the sulcus IOL was indicated in one case, and anterior chamber IOL was given in one case, and intraoperative posterior capsular plaque is in one case. And postoperatively, AC flare, AC cells, corneal edema, and postoperative intraocular pressure spike was seen in group 1, that is in pseudoexfoliation syndrome cases, than group 2. Discussion: most cataract surgery in eyes with pseudoexfoliation can be performed under topical anesthesia. Most surgeons prefer peribulbar anesthesia, especially in cases with small pupil, weak jonules, and hard cataracts, to minimize ocular pain caused by stretching of small pupil during phacoemulsification. A well-dilated pupil is one of the main requirements for safe and successful phacoemulsification surgery. This is even more important with the pseudoexfoliation syndrome, in which surgery is more complicated because of the risk associated with loss of jonular integrity and poor pupillary dilatation. The smaller continuous curvilinear capsular axis was intentional and meant to maintain the capsular axis margin safely within the pupillary area and thus under direct visualization of the surgeon. Harder cataracts are prevalent in our part of the world. Using stop and chop technique, where during chopping all forces are directed to the center of the nucleus so that it can be used to divide the hardest nucleus with minimal stress to the capsular bag and jonules. In addition, first a central space in the nucleus is created, and then the entire nucleus is divided into small wedge-shaped segments which are consumed within the central space in the capsular bag. This allows phacoemulsification without the risk of undue stress to the jonules. Higher postoperative inflammatory response in patients with pseudoexfoliation in the form of AC flare cells, corneal edema, and inflammatory membranes are raised. Intraocular pressure is noted. The significantly higher postoperative inflammatory response is in patients with pseudoexfoliation can be attributed to the transient breakdown of the blood aqueous barrier that occurs during phacoemulsification in patients with pseudoexfoliation. In addition, iris vessels are pathological with an increased permeability of the proteins in eyes with pseudoexfoliation. Conclusion: cataract eyes with pseudoexfoliation tended to show more anterior chamber cells in the immediate postoperative period. Phacoemulsification can be performed safely by experienced surgeons in eyes with pseudoexfoliation. Follow-up studies for longer duration of time may be required to assess final visual outcome due to the occurrence of posterior capsular opacity, anterior capsular changes, and late intraocular lens decentration and dislocation in these eyes. These are my references.